hour. Margarita will introduce Orlando Harris, who will introduce Greg, but Greg, we're just thrilled you're here, so I'll turn it over to you, Margarita. Thank you.
Thanks, Monica.
Thank you, Monica. So yeah, why don't we go ahead and get started? It's about 9:02. So it's my extreme pleasure to introduce our first speaker and our early career scientist, Orlando Harris. So Orlando is an assistant professor in the School of Nursing here in the Department of Community Health Systems in the School of Nursing. He also has a secondary appointment in the Division of Prevention Science, so in my division. So really happy to have him speaking today. He's also a graduate of our postdoc program at CAPS, the training TAPS program. So his research focuses on the exploration of risk and protective factors in sexual and gender diverse communities of color. He also has been focusing on understanding the relationships between intersectional stigma, violence, mental health, HIV, and other health-related behavioral outcomes. He leverages multi-methods data collection. He uses and is committed to a community-based participatory research methods. He's really interested in informing culturally relevant interventions that improve the lives of vulnerable sexual and gender diverse communities. And his research really aims to reduce disparities in health within these communities by developing programs that improve self-efficacy and promote resilience. Orlando has been appointed as an expert panelist on the COVID-19 Prevention Network, and it's a panel funded by NIAID to really review all COVID-19 related vaccine trials. He also has been included in the video for Greater Than COVID-19, and that really targeted the African-American community to overcome vaccine hesitancy. If you haven't seen that video, please watch it. It's really well done, very persuasive. I've shown my dad that video. So really important work. So most recently, his research has shifted to explore factors related to COVID-19 vaccination uptake among Black and African-American communities, which is what he is going to talk with us about today. So Orlando, thank you for being here today. I'll turn it over to you.
Thanks, Monica. Margarita, I'm sorry. I'm looking at both of you guys on my screen. I want to get started and just talk about my talk today, looking at vaccine hesitancy. I don't like using the term, but it's the new thing that's all over the press. So I'm hoping that after today, we'll move away from vaccine hesitancy and talk about some of the real issues really impacting COVID-19 uptake in all communities, but more specifically communities of color. But before I get started, I want to just start with this quote by Audre Lorde, where she says, there's no such thing as a single issue struggle because we do not live single issue lives. Our struggles are particular, but we are not alone. What we must do is commit ourselves to some future that can include each other and to work toward that future with a particular strength of our individual identities. And this really truly speaks to how I also approach my work. When we look at the impact of COVID-19 on communities of color, we see the disproportionate impact of the pandemic. Black African Americans make up 13% of the US population, but account for around 24% of COVID-19 related deaths. And in fact, the death rate is actually 3 times higher than those of white Americans. And of course, there are factors that are fueling this disparities, and I'm sure that Greg will get into some of that in his talk. But just to talk about some of the social and cultural structural inequalities that Black African Americans experience. I will say some of the factors that are impacting COVID-19 related acceptance. You look at the unprecedented speed in which the vaccine was developed, and of course this deluge of misinformation on social media, and of course this sort of like not just the misinformation on social media, but also a disinformation factory on TV too as well. And I will say, in talking with Black African Americans here in the Bay and also in Detroit, there was a general consensus that the term Operation Warp Speed really did a disservice to the vaccination effort. And that speaks towards the speed in which the vaccine was developed, and people thought that it was politicized in the sense that it prioritizes speed versus everything else. And of course, we think of medical mistrust as a major factor too as well. And as I look through this and in talking with research participants in focus groups, you realize that it's a lot of the hesitancy that we're hearing is really deeply rooted in historical and contemporary experiences of systemic racism and marginalization. And in fact, when you talk to people and ask them about this sort of like historical, and I know in the media and across social media, they talk about Tuskegee, but if you really talk to young people and even some older people, they're not telling you exactly, or they are not able to tell you exactly what what went on in Tuskegee. They just knew it was a bad thing. But what people are referencing today are the contemporary experiences of mistrust, discrimination, stigma, etc. So even though we've spent so much time talking about Tuskegee, we should really be focusing on some of those contemporary experiences today. And of course, while the different vaccines became available, a ton of news have been printed and on TV that talks about vaccine hesitancy among Black communities. But what they're really not talking about is the access issues. So, and it's easy just to say folks are hesitant, but we don't talk about the barriers. We don't talk about access to the vaccine, not being able to get an appointment, a proper appointment or a timely appointment. And in fact, if you look at this graph by the Kaiser Family Foundation, it really speaks to the rate of vaccination between Black and white. And if you look at the different demographics, it's not much of a difference per se. It's a 9% difference between Black and white. So folks are getting vaccinated around the same rate. And if you look at the bottom graph in terms of folks who are saying they're definitely not interested in taking the vaccine, you see that there's still not much difference between white and Black too as well. So that all this news around hesitancy among Black communities and so on, it's completely overblown. Now, I did a quick search just to look at some of the articles that have been written recently on COVID-19 and vaccine hesitancy. And if you could see from the first graph up here, between last year and now, we've seen over 431 articles that have been published. And then if you really factor in and looking at race, for example, only 14 or so were written or been published around COVID-19 vaccine hesitancy and Black Americans. And I say all of that to say there's really little difference between hesitancy between whites and Blacks. Same thing in terms of folks' racial differences in terms of vaccination rates over time. And we're seeing that similar to this graph here, that Black and white Americans are getting vaccinated almost at the same rate. Now, let's look at some of the vaccine success, for example, with the polio vaccine in 1955. I looked at this, for example, and think about even the picture and looking at what was going on at the time in this era and factor in the Tuskegee study that was also going on and the trust of science. But if you look at what they're saying, the difference between then and now is that Americans had a especially deep respect for science. And I'll factor in by saying, I'm sure if we look at racial differences, we might have a different take. But the CEO of March of Dimes said, people across the country felt like they were called to duty. It was a call to action, like the war effort. Now, if we understand the cycle of COVID-19 acceptance, we really have to first look at, I first developed this conceptual framework by adapting it from Prochaska Di Clemente, Stages of Change, or the trans-theoretical model, to try to understand this process of vaccination. So going from folks who are vaccine skeptics to folks who are vaccine curious, folks who are vaccine ready or preparation, of course, those who are ready for action. And what we realize is that folks who are vaccine skeptics, they have different sort of like vaccination beliefs. They're not interested or they don't trust the vaccine for various reasons. And I'll get into some of those. So for example, I think that this cycle of vaccine acceptance, especially for those who are skeptics, it's on a continuum. It is separated by those who are intervenable and those who are not. And I had a conversation with Michelle Andrinzik, who's out of the co-VPN in Seattle, Washington. And we had this conversation about, are people who are really anti-vaxxers, are they movable? Are they intervenable? And that conversation was quite interesting in terms of this belief that you're not going to be able to reach those people. So don't spend time in trying to convince them to get the vaccine, but spend time talking to folks who are actually skeptics, they're movable, and they just need additional information or resources from you. So I think there are a lot of factors that are contributing to vaccine hesitancy, and we see that playing out in the news. So there are different levels of vaccination attitudes that will require focused intervention. So some of those include medical mistrust. We think of, like I mentioned before, the historical and contemporary experiences. We think about trust within communities, this layer of misinformation and conspiracy theories, and of course, this bi-directional trust that needs to be involved as part of that process and separating facts versus fake or misinformation. And for folks who are vaccine curious, they're really interested in the vaccine, but they have concerns around the safety and effectiveness, worry about side effects and long-term consequences, still concerns around the use of mRNA technology. Again, like I mentioned before, the speed of the vaccine development. And you have folks who just want to wait and see. And those are people who I like to work with too as well, because you can provide more information around vaccine literacy that will help to move them. So if you look at this graph, for example, as well, in terms of asking, have you received at least one dose? There's not much difference, again, in terms of the racial demographic, but the difference here to point out is political affiliation. And you see that as a big difference in terms of whether or not they already got vaccinated, they're interested in getting the vaccine, or to wait and see. Now, in terms of this, understanding this cycle of vaccine readiness, you have the safety and efficacy concerns, barriers, and also enablers. So in terms of self-efficacy, the patient makes the decision to take the vaccine, and they might initiate some steps towards taking it, but they require additional skills, one, to make an appointment, or to have access to the vaccination site. Keep in mind that at any point, like for example, the news report that came out from from J&J with that hold, news reports like that can immediately move someone back to, say, being a skeptic or just not being ready at all. So some of the other barriers that I mentioned before in terms of language barriers, access to the internet. There's one focus group that we did where we found out that these churches in Oakland that had set up their own vaccination sites, when they opened their doors, majority of the people who showed up for their dose of the vaccine were a majority white, and these were churches that were predominantly in black neighborhoods. So what those churches had to do was to set up their own appointment system and schedule their parishioners personally to get them in. And in one weekend, they were able to vaccinate over 5,000 people from the community. So
Orlando, I'm sorry to cut in. Just one more. You have one more minute.
Sure thing. So I think when we look at some of the reasons for wanting to take the vaccine, folks talk about protecting themselves, protecting their family, wanting to get back to normal, and of course, transparency from trusted sources. Some of the other things to think about too is that to mention to people that the vaccine is free, the vaccine is available regardless of immigration status, and of course to have communication via trusted community messengers. I will say in terms of the vaccine acceptance stage, someone in this the action stage of the cycle may actively seek an appointment for the vaccine or plan to complete their vaccination within a reasonable time frame. And so I'll end here, and just to say that we actually use this framework to train well over 600 plus case investigators and contact tracers here in the state who have been redeployed to call people across the state to get them to sign up to actually take the vaccine.
Thanks, Orlando. Unfortunately, we won't have time for questions. So maybe we can move on to having you introduce our next speaker.
Sure thing. let's see. Second. Oh, okay. All right. So I have the great pleasure to introduce our speaker today, Mr. Greg Millet. He is the Vice President Director of Public Policy at amfAR.
Sorry.
That's all right. At amfAR, which is the Foundation for AIDS Research. Mr. Millet earned his undergraduate degree from Dartmouth College before completing his master's in public health degree from the University of North Carolina at Chapel Hill. Mr. Millet is a well-published and nationally recognized epidemiologist and researcher with significant experience working at the highest level of the federal HIV policy development at both the White House and the CDC. From 2009 to 2011, Mr. Millet served in the Obama White House Office of National AIDS Policy, where he coordinated the office's policy and research activities, including HIV prevention policy and co-writing the National AIDS Strategy. During his tenure at the White House, Mr. Millet also worked on a diverse array of policy issues, including the elimination of HIV entry ban that prohibited HIV positive persons from traveling to or seeking residency in the United States, the temporary suspension of the ban prohibiting federal funding for domestic or global needle exchange programs, and the reallocation of CDC HIV prevention resources using a new funding formula for state and local health departments that better align funding with current disease burden. Mr. Millet also published over 40 peer-reviewed research papers in leading health, policy, and public health journals. His work has been cited with changing the underlying assumptions among researchers of observed HIV disparities among Black men who have sex with men, and he's widely recognized as one of the first researchers to show no protective effect associated with male circumcisions for MSM. I have had the pleasure of working with Mr. Millet on several community projects led by Black gay men over the years. In addition to being one of the most prominent scientists in the field, Mr. Millet has a reputation of being exceedingly thoughtful, kind, and encouraging to young investigators like myself. I have learned a great deal from him over the years, and I'm honored to welcome him to UCSF today. His talk is entitled COVID-19 Health Disparities, A Year Later, and Lessons Learned from HIV. Please join me in welcoming my academic hero, Mr. Millet.
Thank you, Dr. Harris. It's wonderful, spending the last year, and as a matter of fact, during all this COVID-19 work with you, and inspired by the work that you've been doing as part of the CoVPN. I'd also like to thank Dr. Lightfoot as well as Dr. Gandhi for the invitation today. Coming to UCSF always feels like coming home because there's so many friends, co-workers, and mentors who have come through the program and remain at the program. And it's really a pleasure to be here today, so thank you. I'm going to talk a little bit about COVID-19 and where we find ourselves a year later in terms of racial disparities and some of the lessons that we can learn from HIV. And before I begin, I know I bring up Faulkner's phrase over and over again, but because it's so apt, unfortunately, that the past is never dead. It's not even past. And in many ways, we find ourselves going through exactly the same motions across epidemics that we have in the past. And we certainly have done that with COVID-19. So in terms of an outline for my talk, I'm going to talk about what's old is new again, similarities between COVID-19 and HIV, some of the similar racial and ethnic disparities that we see with COVID-19 and HIV, as well as some of the lessons learned and what could potentially make a difference. So in terms of some of the similarities between COVID-19 and HIV, and some of these I'm just going to go through fairly briefly, but first is just the scale of both of these pandemics. With HIV by 2009, over 38 million people infected worldwide, 1.2 million people, or 1.7 new infections taking place each day worldwide each year, and then 690,000 deaths. And with COVID-19, we have 155 million cases, 3 million deaths. In the United States, we have 32 million cases, about 575,000 deaths, and just the massive scale of both of these pandemics in such a relatively short period of time. But there's also a lot of echoes that we see between COVID-19 as well as HIV. When I speak with a lot of friends who have lived through the worst of the HIV epidemic, a lot of people talked about having these flashbacks about testing positive for COVID-19 and when they first tested positive for HIV. And I think many of you have also were surprised when we saw the obituaries coming out of Italy last year, where you saw pages and pages of people who were dying from COVID-19, and really harkening back to the worst of the HIV/AIDS pandemic in the 80s and the 90s, where we saw newspapers filled with young men who were dying from HIV. Another similarity that we see is the geographic spread is fairly predictable, where with HIV began in the coastal cities and then sort of spread to the interior of the United States. And we certainly saw the same thing with COVID-19, where in March and to May, we saw first this rise in the coastal cities and then a decline, and then rise in the non-coastal cities. And then by September of last year, you could see that COVID-19 deaths, the greater proportion, were in those red states, mainly in the interior of the US. And there was a flip between blue states and red states in terms of deaths for COVID-19 over the span of the year. Another thing that we see that is similar between HIV and COVID-19 is this very late recognition of differences by gender and how these pandemics influence women. Yes, HIV, disproportionately impacts men in the United States, but we had a very late start in recognizing, and not until 1993, that HIV also disproportionately impacts women, and specifically women of color in the US. And that was when CDC changed their definition. With COVID-19, we also see that it disproportionately impacts men, but women are also quite vulnerable to COVID-19. We've seen that women are also quite vulnerable to the epidemic in terms of the recession that's taken place due to COVID-19, where more women who are non-college educated lost jobs over that period of time. We also saw the fact that within the pandemic, that there was a rise in intimate partner violence during lockdowns and COVID-19 in the United States and elsewhere that, of course, disproportionately impacted women. And right now we're seeing that there are greater side effects for the COVID-19 vaccines, specific vaccines, among women as compared to men. So in both cases, there was this late recognition of some of these gender differences with these pandemics. We also find ourselves replicating ineffective policy. Many of you remember the ban on HIV positive travelers and immigrants in the United States. A lot of that was part of the reason why we didn't participate or have the International AIDS Conference in the US for nearly 20 years. But that ban was ineffective because we already had quite a few number of people who are living with HIV and transmitting HIV in the US. The same thing happened with COVID-19, where we banned flights from Europe as well as flights from China, but we already had COVID-19 circulating and being transmitted here in the US, and these travel bans really didn't work. We're also seeing this sort of reprise in terms of the dialogue around mandatory testing or mandatory vaccinations and vaccination passports. We remember when the Reagan administration did not call for compulsion or compulsory mandatory testing. We're seeing right now that the Biden administration is not going to mandate a vaccine passport system. We're having a lot of these same conversations that we had many years ago with HIV, again with COVID-19. Another thing, of course, that's similar that we see over and over again in the literature is the degree to which these diseases affect the most marginalized populations. And these are data from New York City early in the pandemic, around June of last year, where you could see that the greatest number of cases, the greatest number of hospitalizations, the greatest number of deaths were among those individuals who lived, had the highest levels of poverty in New York City. And the lowest number of cases, hospitalizations, and deaths were people who were relatively affluent. We've seen that as well for HIV in many different studies. This was a study that CDC released as part of their MMWR, looking at HIV among heterosexuals in primarily urban areas, where HIV again was higher among people with lower school education, unemployment, live below the poverty level, or greater degrees of homelessness. The other thing that we see that's taking place too is sort of this community blaming and shaming. Just as recently as 2015 with Truvada, where men within the gay community were calling each other various types of names. There was this stigma that was associated with using Truvada, and we're seeing the same thing with COVID-19 last year with people who were attending various festivals who subsequently tested positive, and people telling them, well, you should be ashamed of yourself for going to these types of things. All of this, which is not necessarily helpful in getting people to curb behavior. And all of that also translated into externalized stigma. So very early on in the HIV epidemic, we had the 4 H's with hemophiliacs, Haitians, homosexuals, and heroin users who were identified as the groups that were at highest risk for HIV, and subsequently, ballooned into many other supposed crises that we had in the United States, such as the down low, which was really problematic and basically was just pathologizing bisexual men in the United States without very much evidence that they were infecting their female partners at very high rates with HIV. And then unfortunately, the stigma is something that remains. It's something that we see is pervasive throughout the HIV pandemic. Just a few years ago, Charlie Sheen revealed that he was HIV positive, but he was being blackmailed about his HIV status by his girlfriend and being asked to pay millions to keep it secret. And of course, the media went right for the salacious details of whether or not he might have infected any of his partners, despite the fact that he was virally suppressed. So we see this stigma is something that is pervasive and takes place with different groups. Unfortunately, we're living right through this right now. Certainly in San Francisco, New York, and others have been in the news with this wave of anti-Asian racism and attacks that have been taking place during COVID-19, where unfortunately we haven't learned our lessons from stigmatizing various communities from HIV that we're replicating exactly the same thing with COVID-19. And unfortunately, this pathologizing really extends into investigating the origins of disease. With HIV, there was this whole issue of taking a look at what's taking place in different African countries, this issue of bushmeat, and pathologizing some of the populations and groups that were eating bushmeat. And we're seeing the same thing with COVID-19, with China and Wuhan's wet market, and now people are talking about India's wet markets and whether or not that can be triggering the next pandemic. So unfortunately, we see a lot of the same things happening over and over again. But one of the biggest things that we see is the contributions of the social determinants of health for both COVID-19 as well as HIV. And there was a nice report from the National Academy of Sciences that found that healthcare accounts for only 10 to 20% of the determinants of health, but socioeconomic factors related to the physical environment account for up to 50% of the determinants of health. And there was a paper that I just wrote last year where I was taking a look at some of these social determinants of health and how they really aggravate some of the health inequities that we see by race and ethnicity for both HIV and COVID-19 and how they're similar between both of these pandemics. And that's where I'd like to really spend most of my talk, is talking about some of these health inequities by race and what we're learning a year later and what we have seen. Just like with HIV, as Orlando had mentioned, where we see that it disproportionately impacts African Americans, American Indians, as well as Latinx populations compared with whites. We're seeing exactly the same thing that's taking place with COVID-19 over the past year. And the thing that is a hallmark of this that is very interesting was how quickly we saw these disparities appear with COVID-19. These are data that were from May 20th of last year, where they found that in different states, they compared the proportion of the population that was Latino versus a proportion of the population by May 20th that had already been diagnosed with COVID-19 among Latinos. So for instance, in Minnesota, it's 5.5% Latino. At the time, 22% of Latinx populations were diagnosed with COVID-19. Virginia, 9% Latino, 44% diagnosed with COVID-19, and so on and so forth. So the scale of this devastation within communities of color happened very early with COVID-19. There are also even data from American Indian populations from June 5th of last year, where they found that among some of the tribal nations, that the rate of COVID-19 diagnoses were higher in several of these tribal nations and higher than some of the states that were most devastated by COVID-19, such as New York and New Jersey, et cetera. So again, these different populations that are at disproportionate risk for HIV also at disproportionate risk for COVID-19. And then a year ago today, actually, my colleagues and I released a paper where it was the first paper to really take a look at the scale of COVID-19 among African Americans nationally compared to all other groups. And we released this graphic at the same time where we basically found in these orange cases, which are the counties that are disproportionately African Americans, that these counties that were disproportionately African American also had a disproportionate proportion of cases and deaths in the United States. So unfortunately, one of the things that we see over and over again, and we saw this with HIV, was blaming the victim. The first thing that we do is to say, well, what are these populations doing wrong with HIV and African Americans as well as Latinos? Is, are they engaging in greater rates of drug use or have greater sexual partners, et cetera? And my colleagues and I and many of you have been very successful in debunking a lot of those issues in terms of blaming the victim. We saw the same thing with COVID-19, where for a lot of the discourse was talking about the degree to which Blacks and Latinos had greater rates of comorbidities such as diabetes, heart disease, et cetera, and that was what was driving these rates of COVID-19 within these communities, with even the HHS secretary saying that these comorbidities were at the reason why we're seeing these greater rates. But in the analysis that we published and in subsequent analyses that have come out, when we took a look at those counties that were disproportionately African-American, yes, we did find that they had greater rates of diabetes, heart disease, HIV infection, and cerebrovascular disease. But none of those in multivariate analyses were associated with the elevated rates of COVID-19 cases or deaths in disproportionately Black counties. And there have been other investigators who have found exactly the same thing that we have found. And as a matter of fact, there have been several surveys that have found that African Americans and Latinos take more precautions against COVID-19 compared with whites in terms of mask wearing or even social distancing, and that is not what is putting some of these communities at greater risk. In fact, what is putting them at greater risk are some of these social determinants, a lot of the things that have placed these communities at greater risk for HIV. We know that 40% of deaths have taken place for COVID-19 within nursing homes. And this is part of a chart that Kaiser Family Foundation has put together, and many others as well, where they're looking at the demographics of some of these nursing homes and COVID-19 deaths. And they found that as of October of last year, those facilities with a high share of Black residents, 63%, had at least one COVID-19 death. For those facilities with a high share of Latino residents, 55% had at least one COVID-19 death. For those facilities with a high share of white residents, only 37% had at least one COVID-19 death. And in subsequent analyses that have been published by other researchers, we found that the two primary reasons that are driving these disparities is one, where are the staff coming from who work in these nursing homes? And they found that staff that come from counties or zip codes or other areas where there's a high proportion of people who are infected with COVID-19, that they are more likely to bring the infection into their nursing homes. And that's what we saw there. The other thing that we saw as well was, those nursing homes that were in disproportionately Black counties as compared to white counties had higher cases of nursing home deaths. So again, these disproportionate accounts of the social determinants of health that is associated with greater disease in Black or brown communities. And a lot of that brings us to the role of residential segregation. There's been an awful lot of research done on residential segregation in the US. We published a paper last year where we looked at it with COVID-19 and found that those counties that were disproportionately white had fewer cases of COVID-19 cases as well as deaths, whereas those counties that were more diverse had greater cases of COVID-19 cases as well as deaths. And there are other researchers that found the same thing. This is another researcher looking at Latino white segregation. And as you take a look at those counties that have higher rates of Latino white segregation, you see greater number of COVID-19 cases as well as deaths in Latino communities. And of course, we see the same thing for HIV as well, where those counties that are disproportionately white, we see fewer HIV diagnoses as compared to those counties that are far more diverse. So this is something that is historical, that has not changed. We see it for HIV, we see it for many other diseases. The other thing that we saw with COVID-19 was the degree to which we homogenized many of these communities, that Latinos in general were at high rate of for COVID-19, or African Americans in general, without realizing that there are differences. We published a secondary paper taking a look at Latinx populations in COVID-19. And what we found is that as the Latinx population increased in various counties in the Midwest as well as the Northeast, we also saw higher rates of COVID-19 among Latino populations. So much so that in the Midwest and in the Northeast, that only 4% of the counties in the Midwest were disproportionately Latino, but they were still 32% of cases for COVID-19 in the Midwest. And in the Northeast, only 11% of counties were disproportionately Latino, but there was 63% of cases. So there was this regional thing that was taking place. There was another paper that was published immediately after ours where they were looking at differences among Latinx populations in COVID-19 diagnoses. And what they found were greater rates of COVID-19 cases being diagnosed among Puerto Ricans, in particular in the Northeast and the Midwest, fewer in the South. And then those who are Central American, greater rates of COVID-19 for those in the Northeast and the Midwest. But again, showing that compared to Mexican Americans, Cubans, or South Americans, that there are differences among Latino populations in terms of diagnoses for COVID-19. And this is very much the same thing that we see with HIV, where we see higher rates of HIV by being diagnosed among Dominican Americans, among Mexican Americans, and among Puerto Rican Americans as compared to, say, Argentinian Americans. So there are these differences that we see among these diseases and in these epidemics. The other thing that is similar with HIV as well in some of these racial disparities is the proportion of these populations that are not proficient in English, as so, you know, English, not speaking English as an indicator of marginalization. And there was a paper by Nanette Bembo that earlier this year found that for those counties that were disproportionately Latino, where we saw higher rates of HIV disparities among Latinos, that one of the biggest predictors was not speaking English within those counties. And there was a paper that was published in JAMA that found the same thing for COVID-19, where monolingual English speakers in this forest plot, compared to monolingual English speakers, those who didn't speak English were far more likely to be diagnosed with COVID-19 and also far more likely to die from COVID-19. And when they also broke it down, they saw that they broke it down by different nationalities that unfortunately it held. So for people who spoke Amharic primarily, or Cambodian, Khmer, or Somali, Spanish, Tagalog, Vietnamese, all had greater rates of COVID-19 compared to monolingual English speakers. And of course, that is a marker of marginalization. And then what we've all noticed and we knew was going to happen was the degree to which when you have new technologies that the communities that need it the most are least likely to have access to it. We've seen that with ART in the United States, with African Americans and Latinos at the very beginning, least likely to have access to it. We are seeing the same thing currently right now with PrEP. And then of course, we saw the same thing with COVID-19 testing in the US, where testing sites were not placed in those communities where we already knew there were higher rates of COVID-19. And that was something that took place all over the nation. And it was so much of a concern for me last year. It's actually exactly a year that I released my study. And this is one of the quotes that I gave for Vox, where I told them the reason that we released this study so early is that we didn't want to see history repeat itself. And especially when a vaccine becomes available, that we wanted to make sure that Black and Latino communities had access to a vaccine. But unfortunately, history has repeated itself. And exactly as Orlando had mentioned, we're seeing that, you know, many of these COVID vaccine sites, at least in the very beginning of the rollout, was not necessarily placed in Black or Latino neighborhoods where people had to travel farther for that. The other thing that we're seeing with COVID-19 as well as HIV is a degree to which people don't really realize or undervalue that this is part of a syndemic. That these are multiple reinforcing epidemics that are taking place with COVID-19, HIV, opioids, and as well as hepatitis C. And for one example of that, you know, CDC has been releasing data, quite a bit of data over the last couple of months of the rise in overdose deaths that have been taking place during the COVID-19 pandemic in the US, with an increase as much as 38% of opioid deaths, for synthetic opioids, for cocaine deaths, increase of 26%, and psychostimulants, an increase of 35%. And we're seeing how this plays out among race as well. There's a great paper that just came out in JAMA where they were looking at non-Hispanic whites, non-Hispanic Blacks, as well as Hispanic individuals, where you could see fairly clearly that over the period of time from 2019 through 2020, about from February 2020 through April of 2020 on, we see this jump in fatal overdoses among African Americans, and it's actually eclipses whites in the United United States. And we see the same thing in this jump in non-fatal overdoses over that period of time among African Americans and eclipsing whites in the United States. So we see that these two pandemics are reinforcing one another and actually making the situation worse in terms of disparities by race and ethnicity. There's also a great paper that Nora Valco just published a couple of months ago, where they're looking at COVID-19 hospitalizations and deaths by race among substance using populations. And what they found is, in terms of hospitalizations among people who use any substances, that those who had recently, those who had used any substance use, that the rates of hospitalizations for COVID-19 were higher among Blacks compared to white substance users. Those who were recent substance users, again, you see this profound greater rates of hospitalizations among whites compared to Black substance users. And unfortunately, the pattern repeats itself in terms of deaths as well, with any substance use for Blacks versus whites versus recent substance use of Blacks versus whites. So again, goes to show that these are syndemics. These are multiple reinforcing epidemics that help to reinforce some of these inequities that we see. So this brings me to the end of my talk and some of the lessons that we've learned from HIV. One of them is that we can reduce disparities. And some of the ways that we've seen that being done is, for instance, in the Ryan White program of HRSA, where in 2010, only about 70% of the individuals in HRSA's Ryan White program were virally suppressed. By 2019, it jumped 19 percentage points. And we see particularly that these jumps took place among African Americans, took place among those with unstable housing, took place with many different groups where they were able to increase viral suppression. So it's something that we can do. We also know that there are various policies that are associated with good outcomes that could increase viral suppression in the United States. There's a paper that the CDC published where they found that death rates among people living with HIV were lower in states that had higher levels of healthcare coverage, that had greater anti-discrimination laws, and where there was greater viral suppression among Ryan White clients, which really shows that states can influence HIV outcomes through programs as well as policies. The other thing that's taking place right now, too, that is going to be helpful is the fact that COVID-19 has really disturbed the budgets of so many states that many states that have not up to this point elected to expand Medicaid are now electing to expand Medicaid, where we see that Missouri and Oklahoma are expanding Medicaid. There are others that are looking to expand Medicaid. And why this is important is because there's an analysis that found that states that have expanded Medicaid are better positioned to address COVID-19 and the recession, and that over 650,000 uninsured essential workers are likely to gain Medicaid coverage, insurance coverage, when their states adopt Medicaid. And of course, these essential workers are disproportionately Black and Latino, who are not only at greater risk for COVID, but at greater risk for HIV as well. The other thing that is encouraging is the degree to which people are recognizing that health equity can reduce health disparities. So there have been several studies that have been coming out of the VA that I've been pointing out, where they find that even though Blacks and Latinos are more likely to be infected with COVID-19, that in the VA system, they are less likely to die from COVID-19. And a lot of that is a focus on health equity within the VA as well as within the military as well, compared to the general population. What's exciting about this is that there are algorithms that we can have, that we could produce that could reduce some of these racial disparities that we see. And many people are talking about this as ways that we can reduce racial disparities. And it's certainly important for HIV. There was a great paper that Patrick Sullivan and his colleagues published where they found that the CDC guidelines for pre-exposure prophylaxis were really not that great in predicting HIV diagnoses for people of color. So for instance, they were able to capture those men who have sex with men who are white, who were at high risk for seroconverting with HIV, far less so for Black men who subsequently seroconverted for HIV within their cohort. So now CDC is working to try and revise those guidelines so it can be better at capturing Black communities who are at greater risk for HIV. So just changing algorithms and guidelines could help. And we know that this health equity model could reduce HIV incidence rate ratios between Blacks and whites. There's a paper that Eli Rosenberg published in Lancet that I was a part of, where we were just modeling if we had equivalent care by race and ethnicity, if we could reduce the incident rate ratio in HIV between Black MSM and white MSM, and indeed you can. The other thing that we can do is that we can exploit the syndemic and some of these dynamics that are taking place. One thing that's been interesting with COVID-19 is that there's a greater number of people who are being diagnosed with acute HIV. There are papers from Chicago, from San Francisco, and other places where they're finding in emergency rooms, people are presenting with fever, people are presenting with diarrhea, thinking that they have COVID-19, but subsequently being diagnosed with HIV. And many of these cases are primarily African-American. And there was a great paper, a modeling paper that looked at linking opt-out HIV testing with COVID-19, where they found that they could substantially reduce the number of HIV infections over a period of time in 6 cities that are part of the Ending the HIV/AIDS epidemic. So this is something that we can do. We can easily make sure that COVID-19 testing is paired with HIV testing. The other thing that is helpful for us to remember too, in terms of these syndemics, is that it's not a disease-specific research investment. It's certainly not a zero-sum game. So the investments that we have made, the gains that we've made in HIV research has benefited hepatitis C. It's benefited certainly the development of the Ebola vaccines and now the COVID-19 vaccines. So in many ways, we have to keep reminding people that the lessons that we've learned from HIV and the research that we've done for HIV has not only benefited HIV, but other diseases as well. And the other thing, of course, that we've learned is that shaming just doesn't work, that we have to focus on harm reduction. We have to figure out how to make things safe for people. And it's something that HIV has done well, that we're relearning again with COVID-19. And this is just a chart from the Scott County outbreak, where over 200 people who used opioids back in 2014 and 15 became infected with HIV. But you can see the leveling off of HIV cases as soon as a syringe exchange program was introduced. And then, of course, we know that leadership saves lives. It's great that Dr. Eric Gooseby, who is on this call, Ambassador Gooseby, and all of the amazing work that he's done as part of the PEPFAR program, and certainly the work that former President Bush has done in implementing PEPFAR and how it saved millions of lives across the world. Leadership matters in the middle of a pandemic, and unfortunately, the leadership failed for the last administration, where that's roughly 40% of US coronavirus deaths could have been prevented in a study that was published in The Lancet. And that's something that is certainly another lesson learned from HIV. And I think the last lesson is that, acting globally is acting locally. You can see that most of America is far ahead of the curve in receiving vaccinations and being vaccinated compared to the rest of the world. And we're dealing with an infectious disease that affects everyone. We can't live in an island amongst ourselves. But even though the US is 4% of the world's population, 48% of doses for Moderna are at the US, 24% of Pfizer, 13% of AstraZeneca, 30% of Novavax, and 10% of J&J. So we are outstripping our share of the world population in terms of vaccines that are available. And we need to make sure that we share those vaccines with others, just the way that we were able to share and make sure that ART was available for the rest of the world for HIV. So this just brings me to ending from Andrew Sullivan, who I don't always agree with, but I do think that he has some great perspectives on how to survive a plague. And what he wrote was that this will change us. It must. All plagues change society and culture, reversing some trends while accelerating others. The one thing we know about epidemics is that at some point they will end. The one thing we don't know is who will we be by then. And one thing that I certainly hope that we will be is a society that realizes that these disparities are longstanding, that we can avert them, that we're not fated to continue to having these disparities with each pandemic that we encounter, and that we move forward to learning from our mistakes from the past and addressing future pandemics far better than we had for COVID-19 and our initial mistakes with HIV. And with that, I just wanted to thank you for the opportunities to speak today and look forward to any questions that you might have.
Thanks very much, Greg. That was an excellent presentation that really put into focus many of the things that many of us have been thinking about and talking about in terms of HIV and COVID-19. It was amazing. Thank you. So we have about 10 minutes for questions. If you have a question, please go ahead and unmute yourself and ask it, or I can't see everyone on my screen, but you could also use the raised hand function, and we can call on you then. And while we're waiting for the next question, I'll take my prerogative as being the moderator and ask, there's so many things I could ask, but let me just start off with the question around HIV has really been the foundation for the COVID-19 response. And I'm wondering your thoughts on what might be the next steps for kind of maintaining this HIV infrastructure for what might be the next thing coming down the pipe.
Yeah, I think that we have a lot of opportunities. One of the biggest opportunities, of course, is the degree to which so many HIV scientists have been integral to the COVID-19 response, both nationally as well as to the county and state level, and even internationally. I do think that we have an opportunity with the 40th anniversary of HIV approaching just within a month and a half to really digest, where HIV has been able to leverage and lift all boats for many other diseases, not just communicable diseases, but also non-communicable diseases. And talk about what those opportunities have been, but also to talk about the success that we could have in ending the HIV/AIDS epidemic, to finally end the HIV/AIDS epidemic domestically as well as globally, and to link both of them. And then from there to really talk about the lessons that we've learned in terms of blunting some of these racial disparities in HIV and how it's not only applicable to COVID-19, but for other diseases as well. And it seems that this administration is certainly heeding those lessons with a lot of the legislation and policies that are coming through. And I think as a community, it's something that we definitely want to try and support and to move forward.
Yeah, thank you. Monica.
Greg, that was an amazing talk. And I also been thinking about HIV and COVID interactions this whole year. And I have two questions related to what you said. One is, why do you think we didn't take a more harm reduction approach? Because harm reduction is actually the idea that you are trying to reduce transmission. So it was not that you're trying to increase transmissions, you're trying to reduce transmissions, but using approaches that allow behaviors like going to work or being around each other that tell people how to keep safe within those behaviors. And why do you think we didn't stay at home, wear a mask, save lives are not nuanced approaches to a pandemic? And why do you think that HIV wasn't able to inform the COVID response in that one way? And the second I would ask you is if you know anything about COVID vaccine patents and waiving those patents and any secret information about the trade commissioners and President Biden's deliberations these days.
Sure, I can answer the second question very easily because I haven't heard any updates in terms of the COVID-19 patents and what the administration is thinking about. I know that they have been considering whether or not they were going to share the patents for the mRNA vaccines with the rest of the world to move things forward. But from what I've heard, that there's been a lot of back and forth as to how things might move forward. And I think we're all in a bit of a wait and see mode. For your first question, I agree with you. I think that, the harm reduction approach really, it hasn't been democratized. And I think that there's some reasons for that. Even though we've had, for instance, syringe services programs for well over 3 decades, knowing that they work, and lots of hard data showing that they work in reducing HIV infections. When you take a look at polling for syringe services programs, and there's been recent polls from Harvard and recent polls as well from Johns Hopkins University, you find that only about 30% to maybe 40% of the US public supports syringe services programs, even though this is something that's a harm reduction approach that works. Even fewer support something such as a safe consumption site. That I know that San Francisco and others have been trying to introduce. So for some reason, sometimes it's very hard to introduce interventions that we know that work into to society and to make sure that people are using it. There's a part of us that almost believes that if somebody gets a disease that they did something wrong,
yes,
that they deserve it. And that's something that we saw from HIV. We certainly have seen it with COVID-19. And it's sort of this elemental thing that unfortunately persists to this day that is fundamental, that we need to figure out ways that we can change. I think the other reason, and many of us already know this, is that our response that we didn't take a harm reduction approach is because we didn't have the leadership to do that. From the very beginning of the pandemic, the last president said that he's probably not going to wear a mask when CDC was saying that we should wear a mask. And that leadership matters, especially when we see recalcitrance right now to vaccines particularly in red states as compared to blue states. We had an opportunity to have a unified response in preventing COVID-19, a unified response in vaccinations. And unfortunately, a lot of that was squandered by leadership. And that's something that I think that many of us and many others are going to be dissecting for years to come.
Thank you.
Thank you, Greg. Peter, did you want to ask your question?
Yeah, just following up on some of your last comments, Greg. I mean, really, again, thought-provoking, discussion here, and I'm wondering whether the recent rural outbreaks of Hep C and HIV have changed the way that those local communities have viewed needle exchange, and whether there's anything we can learn from that change in perception locally that could be broadcast out to a more national level to help people understand the low percentage of people who are for these harm reduction strategies nationally. Can we help educate people in better ways using experiences like that?
Yeah, no, thanks, Peter. That's a great question. I think we did see a bump up in certain services programs that were immediately after the outbreak in Scott County. It became such a big national news that many states that up to that time had not legalized certain services programs began to legalize them, such as Kentucky and Tennessee and many others. So we saw, this increase of as many as 100 or 150 new certain services programs coming online. I think one of the other things that was helpful was when people saw what the bill was associated with the Scott County outbreak, when CDC mentioned that it was about $100 million that it cost for that outbreak that could easily have been, avoided by a $35,000 a year certain services program being available. So all of that helped. The problem, though, is that those types of things don't stay in the memory of the public for long, even in the places where these outbreaks have taken place. So right now in West Virginia is in the process right now of getting rid of several of its certain services programs, and we're seeing increases among people who are substance users with HIV in West Virginia, and even in Indiana, where we had the outbreak. There has been a wave of different towns and counties in Indiana that have been getting rid of their certain services programs, and we have to figure out what the magic solution is to make sure that this thing remains salient, that people understand that this is not something that is helpful in a specific moment in the middle of an outbreak, but could actually prevent outbreaks. And more than that is something that's helpful for people in their lives generally. Sometimes that messaging just doesn't seem to get out there. So unfortunately, these rural outbreaks are not leading to sustained policy change. And as a matter of fact, we're moving backwards.
I think we have time for one more question, if anyone has one. Okay, let me just ask one last question then, Greg. I'm really happy to hear that you were really addressing this endemics issue. It's something that folks aren't necessarily always talking about, but absolutely all of these things are related. And I've been hearing some thoughts and concerns around folks being worried about we might see increases in HIV and STI risks as a result of people being isolated, and now that things are opening up. Do you have any thoughts, or have you heard about any studies or data that kind of will speak to this issue about whether or not COVID-19 actually might drive up HIV cases?
Sure. Well, we've already seen, the data for congenital syphilis that CDC released during COVID-19 and increases there, particularly among women. I'm hearing isolated increases in STDs from various state directors in various places that STDs have actually increased as we're starting to open up, and even during COVID-19. I suspect that we're going to see an increase in HIV as well. And part of the reason for that is so many people lost their jobs. Their insurance is tied to their jobs, and their PrEP coverage is tied to their jobs. So people might have lost their jobs and their PrEP coverage, but they might not necessarily have changed their behaviors. And so we're going to see some differences there and perhaps some changes. And if people don't have access to insurance and they don't have access to PrEP, then that's something that's going to be problematic. A lot of people are homeless or don't have stable housing. We know that that's associated with not being virally suppressed with some of the great work that many of you are doing in San Francisco. So of course, that's going to perhaps increase HIV. The other big issue too is that, we've gone through this unprecedented period where many Americans are experiencing anxiety and mental health issues. And what does that do as well for not only risk behavior and certainly substance use, but also for HIV rates as well. And then of course, we're seeing what's taking place with the opioid epidemic, as I'd said beforehand, where we're seeing these greater rates of opioid use as well as fatal overdoses. So I do think, unfortunately, that we're going to see an increase in HIV infections, and it's just going to be a lagging indicator. But there's certainly enough indicators that are out there showing that that might take place.
Thank you, Greg. Well, we were at 10:01, so thank you so much to this. Join me in really thanking the speakers, both Orlando and Greg, for really excellent talks today. Thank you for joining us here at the CFAR Symposia, and have a great rest of your Wednesday. Thank you, everyone.
Thank you. Take care.